Introduce our speaker. Thank you so much.
Welcome, everyone. It is my distinct pleasure to introduce Dr. Natalie Moyes, who is Associate Professor of Medicine at the Columbia University College of Physicians and Surgeons and a physician scientist at the Center for Behavioral Cardiovascular Health. Dr. Moyes completed a BA in Psychology in Women's Studies at Princeton, an MD at Mount Sinai, followed by residency in a general medicine fellowship at New York Presbyterian Columbia University Medical Center. She also has received an MS in epidemiology from the Mailman School of Public Health at Columbia and focused training in implementation science from UCSF. Dr. Moyes' primary research focus is in implementation science methodology with an interest in clinical inertia as it relates specifically to depression treatment and hypertension guideline implementation. She is currently PI of several grants, including 2 R01s from NIH and AHRQ, which focus on using informatics approaches to improve the implementation of team-based care at the intersection of chronic CVD and mental illness. Other current work is funded by NIMHD, NCI, SAMHSA, Johnson & Johnson, and the AHA. Unsurprisingly, Dr. Moyes has received many awards and distinctions, and among these, she is Fellow of the AHA, the New York Academy of Medicine, and most recently, the Academy of Behavioral Medicine Research. She's also a member of the editorial boards of several journals, including JAHA and Implementation Research and Practice. And on a slightly more personal note, I first met Dr. Moyes when we were both doing press for the AHA Epi Lifestyle meeting several years ago, and was immediately impressed by both her passion for this work and her poise. I expect you'll agree. Please join me in welcoming Dr. Moyes.
Excellent. Thank you so much for inviting me. That was a great introduction. I actually had an excellent day meeting a lot of you today, so thank you for your warm hospitality. I'm going to go to my next slide. Okay. Can you guys hear me okay? Okay. So they're coming through. Let's just make sure. Okay, great. So as Allison was saying, so I lead an IMSci lab, an implementation science lab at Columbia University, Irving Medical Center. And we've now tested our methods in over 8 grants over the last couple of years. So we've learned a little bit about the pitfalls, but also and the challenges and the opportunities of implementation science. We've done over 250 consultations across the US with policymakers, with AHA more recently, Johnson & Johnson. So I'm going to be talking about some of our research and giving you a sense of how hard it is to do this work, but also potential opportunities. So the learning objectives are to understand some of the fundamentals of implementation science. I think this term is everywhere these days. Not everyone understands what it is or what it does and doesn't do necessarily. So I'll go very quickly through that. I will teach you how to apply implementation science using a behavioral cardiology use case, and then focus on examining ways implementation science can advance cardiovascular research. So I'm going to start with one of my own cases. So Mr. C is a 65-year-old man. He has a medical history of coronary artery disease. He's had multiple PCIs. He has OSA, GERD, hypertension, IBS. He's had recurrent episodes of depression following his last PCI. And so over the last 2 years, he's presented to the emergency department at least 3 times with recurrent chest pain. Every time he's had evaluations, they've been suggestive of non-cardiac causes. He states that he's mostly compliant of his medications in terms of his cardiovascular regimen. His cardiologist has ordered an echo, which was unremarkable. A stress test showed normal myocardial perfusion. He's had 2 left heart caths, all showing non-obstructive coronaries, patent stents. He's had a PET CT more recently. We're waiting for a cardiac MRI. Nothing has really been remarkable. And he's been advised to follow up with his cardiologist. He's completed about 1 to 2 sessions of cardiac rehab, but he doesn't really exercise. He states that he tries to follow a healthy diet, but finds it very difficult to do so. And more recently, he started disclosing some symptoms of just overwhelming depression and hopelessness. And so many of us have had cases like this, and some of us have been very successful in dealing with the kind of behavioral and psychosocial risk factors of our cardiovascular disease patients. And some of us have found it very futile to even address these. And I think I've toggled back and forth between the two as I've gone through my career. And so in many ways, this case exemplifies, I think, the field of behavioral cardiology. We, and now many of our patients now know that there's a link between negative health behaviors like exercise and diet and negative emotions like mindsets, depression, anxiety, and coronary artery disease. We've now tested countless different types of interventions in small efficacy trials, larger trials, looking at things like CBT and sleep hygiene and smoking cessation. Lots of research has come out of this area over the last couple of decades. And one case in point has really been this area of depression and heart disease. There have been decades of research now. We know that depression is common after an MI, up to 30%. That's, I think, a smaller number. So some I've seen with elevated depressive symptoms up to 50%. People have really teased apart what are the patients. It's actually surprising. Depressed versus non-depressed patients actually have a lower prevalence of type 2 MIs, right? And so it's really the type 1 MIs that we're seeing. After an acute myocardial infarction, PCI, CABG, all showing the same. Depression seems to predict risk of cardiac events, mortality. It's associated with hospitalizations, quality of life, costs. There have been decades of research on mechanisms, right? So we've looked at these kind of cardiometabolic risk factors. Many of us in this space believe that it's really driven by behavior. It's mostly the fact that if you're depressed, you're not exercising, you're not following a healthy diet, non-adherence. There's been a lot on kind of the inflammatory states. There have been some interventions where let's give a patient strong anti-inflammatories and see what happens. You can actually reduce their risk of recurrent cardiovascular disease events, but unfortunately, they're dying from infection, so that may not be the right avenue. But there's been a ton of research on mechanisms, and there's still a lot, I think, more to be done in this area. And then we've had decades of research on treatment. We now know that mental health treatment, like antidepressants and therapy, improve depressive symptoms and quality of life after an MI. There have been some more data from cohort studies showing that untreated, so if this is untreated for depression, patients are more likely to have cardiac events than those without depression or those who are treated for depression. Unfortunately, treatment, so one of the largest trials in RICH-D looked at psychotherapy with or without antidepressants for more severe cases. No impact on death or non-fatal MI. And this has been replicated in lots of different trials. More recently, the suggestion is that more personalized, patient preference-driven approaches, collaborative care, where you have a care manager who's tasked with ensuring that patients engage in mental health treatments, that they find the treatment that's personalized for them, tasked with reminding the clinician, either primary care or cardiologist, to titrate their antidepressants, but also their cardiovascular disease treatments. That seems to potentially improve short-term cardiac events, maybe not long-term or medium-term. So that's the kind of bottom line, but the black triangle diamond on the left side shows some short-term impact. We now know that cardiac rehab and exercise can improve depression and cardiac events. More recently, antidepressants like escitalopram might have longer-term effects. Maybe after a couple of years, you start seeing a reduction in cardiac events. And, so far it's felt like the field has kind of stalled after that. It's kind of like, where do we go from here? There has been very little evidence that all of these decades and decades of research has impacted patients like Mr. C in any way. We still have patients like this who are kind of circling the drain with their behavioral risk factors and their psychosocial factors that are still really not being addressed. And so the premise really of this talk is that implementation science gives us shared language and a comprehensive way to approach science that sometimes feels stuck. And maybe like behavioral cardiology, you're in an area that kind of feels stuck. It doesn't look like this is impacting any of my patients. And we're going to be talking a little bit about that. So there's clearly a gap between what we know and what we do. And nowhere, I think, is there more what we know than the field of cardiovascular disease research. We know a lot. There's been a lot of research in this area. And a couple of years ago, the NIH looked into this and they found it takes about 17 years for about 15% of the research that we've come up with to make it into the real world practice, right? And so it takes so long to go from discovery and getting guidelines out and replicating interventions. And so this field of implementation science was birthed to help us expedite this process, understand why it takes so long and what are the barriers to implementing these evidence-based practices into real world areas. And so technically, the definition is of implementation science is the scientific study of methods to promote the systematic uptake of research findings and other evidence-based practices into routine care, all with the goal of improving the quality and the effectiveness of health services. And to put it more simply, we bring healthcare research into the real world. Right. And so the core principles are that this doesn't just happen by itself. You don't just have an evidence-based intervention, then suddenly everybody's using it and we're impacting care. There needs to be these kind of implementation strategies. So there's this difference between the what, which is the evidence-based intervention, so hypertension guidelines, et cetera, and the how, the stuff. The bundle of interventions that we use to get people and places to actually follow guidelines. And the outcomes that we really care about are things like feasibility and fidelity. Are we actually implementing them the way that they were originally envisioned in original clinical trials? Things like sustainability. Can this be done without a ton of NIH dollars necessarily? When we take all of the research individuals out of the picture, can we see the same outcomes? And then service outcomes like efficiency and effectiveness in the real world, timeliness, equity are the other outcomes we care about. Less so clinical outcomes. Those have already been shown to be effective in the original clinical trial. So there's less focus on the kind of clinical health status or symptoms that you would see in a clinical trial. So the next question I usually get is, how is this any different from quality improvement? And so quality improvement has its own methods, right? And so the point is to improve the patient and the provider experience. And it doesn't have to start with an evidence-based intervention. I've done a lot of quality improvement projects where maybe we want to fix how long it takes for someone to be seen in the emergency room, right? So we're just focusing on wait times. That's not an evidence-based intervention. We're just improving things very rapidly. We're not necessarily caring about how something worked or why it worked. And it doesn't even have to involve research, right? You don't have to randomize to do quality improvement research. In some ways, for me, quality improvement is an implementation strategy. It's one of many strategies we can use to get people and places to follow guidelines. Health services research is research, so you're usually comparing two things. And the outcomes we care about are things like adherence and efficiency and safety, for example. And then on the social behavioral science world, we really think about mechanisms, the theoretical underpinnings of what gets people to tick. How do we get people to change their behavior? And to me, implementation science kind of pulls this together. And so we start with an evidence-based intervention, and we really spend a lot of time understanding why aren't people following this guideline. And then we're designing strategies using really kind of theories, models, and frameworks to identify a strategy, test the strategy, usually in a randomized controlled trial, and then really spend a lot of time understanding why did this work, where did this work, what would we actually need to get this intervention to work in the real world. And so a couple of years, colleagues and I wrote a scientific statement on leveraging implementation science to achieve cardiovascular disease equity. And so there are these 4 steps that we usually take. You find an evidence-based intervention, you identify barriers and facilitators, you identify a strategy, and you evaluate. And we came up with this kind of very long checklist, but this is the kind of shorter version of involving stakeholders in every single one of these steps, applying equity-informed implementation science theories, models, and frameworks. And when you think about the barriers, not just focusing on patient-level barriers or physician-level barriers, but structural barriers, and getting a sense of how we can kind of target those with our strategies. And then thinking about things like adaptation. You have these evidence-based interventions that were designed in very rigorous, perfect ways, but to what extent do they need to be adapted for us to actually implement them, are some of the questions we start asking ourselves early in the kind of implementation science steps. And so in mining the evidence, just to go quickly through these steps, we spend a lot of time in the evidence of looking at the effectiveness, looking at the meta-analyses. I was talking to the fellows this morning, when we're writing an implementation science grant, we have these 2 or 3 steps. First, it needs to have a ton of evidence that we should be definitely doing this. The next step, there should be a gap. If everybody's following the guideline, you don't really need implementation science. So you're identifying some kind of practice gap, evidence to practice gap. And you're understanding what were the mechanisms, what are the active ingredients of that intervention that we really need to make sure that we have in place to make sure that we're seeing the effectiveness that we did in the original clinical trial. We usually have this kind of performance gap where we state, okay, if we could get 30 more people to follow this guideline, we would save this many lives and we'd save this many costs and improve quality of life in this way, as we're kind of formulating these implementation science grants. The next step is context. So this is a schematic of CFR 2.0. It's one of the many frameworks that we use. And so this really provides us with a very comprehensive way to look at barriers and facilitators. So we're not just focused on patient level. Maybe it's just, motivation, for example. You're going comprehensively. Is it lack of funding? Is it reimbursement? Is it the outer setting where patients live and breathe in terms of the outer context? Is it the inner context? Is it just very difficult to do this in our healthcare system? We don't have leadership engagement. We are missing there's not the infrastructure in place. Communication, networks of communication is one inner contextual factor. And then the individuals themselves, is it the doctors don't care? Is it the patients don't care? Getting a broad sense of what are the biggest drivers of why it's so difficult to, and every evidence-based intervention will have different barriers. We also spend a lot of time thinking about the innovation itself. Is this a really, really structured 30-week intervention? Is this a short intervention? Is there flexibility in this intervention? Can you trial it? Is it, how flexible is this innovation, or some of the things that you're starting to think about as you're preparing for implementation? And then the next step is to map these two strategies. So we have, Powell and all came up with these 73 different strategies. And so these are the big headings of those 73 strategies. And the premise is that overall, this probably encapsulates about 90% of the things that we do to change behavior, to get healthcare systems to incorporate or implement an evidence-based intervention. So things like interactive assistance. So examples of that are practice facilitation, which many of us have heard of, technical assistance, right? And so if you're a state monitored program, you might be providing some technical assistance as you're trying to implement an evidence-based intervention. Supporting clinicians, reminding clinicians, decision support tools, practice agreements, like with pharmacists, for example. Those are the types of implementation strategies that we often see at the support clinician. It could be train and educate, use financial strategies. The whole point is that you can't use all of these. And we're trying to come up with the most acceptable, generalizable strategies to improve the uptake of a given evidence-based intervention. And it could be that you need something for hypertension guidelines and remote patient monitoring that's completely different for depression treatment guidelines. And so in our statement, we did a scoping review to get a sense of, and this is, I think, the utility of implementation science and having a shared language, is that if you're in an organizational level, if you want to improve cardiovascular disease equity, usually a combination of something like clinician education, team reorganization, CDS tools, standardized protocols are needed, audit and feedback are needed. If you're at the community and policy level, it's usually something around fiscal strategy. So some kind of fee for service or fee for quality component is needed, but meaningful partnerships and quality monitoring and education. And the hope is by the end of this that we would have a sense, if you're going to scale an evidence-based intervention, you would know, hey, for hypertension guidelines in healthcare systems, these are the strategies that are needed to kind of scale remote patient monitoring in these settings. Unfortunately, in our statement, we concluded that we found nothing on behavioral cardiology in implementation science. None of these specified who delivered what, when, why, and that's been a big push in implementation science. So it's really hard to replicate these. And they were just chosen out of midair many of the times, right? And so it wasn't clear, how were they chosen? Do they actually target barriers? What is the mechanism of action? What were the active ingredients? Do you need all of these interventions? So these are big gaps in the field. We still need a lot of implementation science to help us, because it's impossible to do all of these strategies, right? So we need to get a sense to create these kind of very flexible, clear, clean strategies to improve the uptake of our evidence-based interventions. And then lastly is evaluation. So here's an example of one of our projects. We knew that out-of-office blood pressure monitoring is very underutilized in many settings. This is for the purposes of diagnosing hypertension, particularly in primary care settings. And so we looked at all the barriers and facilitators across multiple settings in the US to get at generalizable barriers and facilitators. We then mapped those to strategies. And so we knew that you needed an ambulatory blood pressure monitoring service to actually get this done, some clinician education, EHR tools in terms of order sets. And we saw this marked improvement in clinicians using out-of-office blood pressure monitoring for the purposes of diagnosing hypertension and our intervention practices versus control practices. And I think this is some of the utility, is that you're more likely to have more effective interventions if you use this theory-driven approach. And so what are some of the challenges? I think of doing this in cardiology, it takes a long time to design interventions, conduct RCTs, and build evidence. And sometimes the effectiveness is very nuanced. And it's not clear that this was effective in maybe a small population. And so it makes it hard to think about implementation when you're faced with some of these challenges. Often you have very complex interventions, particularly at the intersection of cardiovascular disease and behavior. Like I said, 12-week CBT interventions can be very hard to implement. Then you have constantly changing recommendations and research. You have new drugs and diagnostics coming out all the time, which again makes it hard. We're starting to do some de-implementation science sometimes just because things fall out of practice in terms of recommendations so quickly. And the environment is not always clear, right? Is it best to do this in cardiology and psychology or primary care? Where is outpatient versus inpatient? And so this can be very difficult. And then there's been a preponderance, I think, of local quality improvement initiatives that are just very specific for a problem in your setting that are not really generalizable. So we can't really learn a lot if you're in a different healthcare system. So there have been very few implementation strategies where you're testing something across a lot of different types of practices to get a sense of what worked or what didn't work and get some generalizable knowledge. The next part of this, I'll be talking a little bit of how you can apply this and answer some of those questions. So let's go back to our Mr. C case in terms of the behavioral cardiology use case. And so the first step we did was spend a lot of time mining the data, right? So it was pretty clear that all of these different interventions can improve depression and quality of life. And you might be doing the same in for your respective problem that you're dealing with and you're trying to implement. But when we looked at the cardiac outcomes, the data was very mixed, right? And so maybe antidepressants maybe have a long-term impact. The one area where you saw short-term effects, in addition to seeing some impact on cardiovascular disease risk factors, like LDL and A1C, was a patient preference collaborative care approach. That seemed to be the strongest intervention. Exercise cardiac rehab was also just as strong, but they had very limited eligibility criteria. So a patient like our Mr. C wouldn't even have been eligible at this point, at least in our setting, to do cardiac rehab. And so as we're mining the data, we're thinking, okay, it seems like patient preference collaborative care is the best intervention for us to implement. The other question you're asking is, are there any effectiveness outcomes that we still, and this helps you decide whether or not you're doing something called a hybrid effectiveness implementation trial. It could be that you're ready for implementation, you're just going to focus on implementation, but there's been a push towards looking at any effectiveness outcomes at the same time. It could be that there are still some questions that we still don't know at the effectiveness. And so for us, there are still some questions. Does this work in the real world? If we were to use real world resources, would we actually see the same outcomes? So there was some interest in real world outcomes in terms of depressive symptoms and quality of life. And then the cardiac outcomes still weren't quite a slam dunk. And the thought is that we were going to try to identify the active ingredients and really target the behavioral risk factors, which we thought were some of the mechanistic underpinnings of why collaborative care and these kinds of programs worked in terms of impacting cardiovascular disease. The next step is implementation gaps, right? And so you might be doing this in your own healthcare system, but the hope is that this is generalizable, that it's not just your healthcare system, but lots of places. And so we know that there are these ACC/AHA guidelines recommending depression screening. This is in cardiology settings. We should be initiating antidepressants, assessing therapeutic adherence, referring to primary care or mental health clinicians. It's a lot to do, right? It's very hard to implement these guidelines. And so if you look at more generalizable knowledge, there have been some efforts to screen everybody in some settings. And they found that even when you screen everybody, very few physicians even recognize that the patient was depressed. And then you go down here. Few had the diagnosis explained. And in the end, only 4 to 6% of patients actually had psychotherapy or antidepressants. And we saw almost nothing mentioned about collaborative care models in cardiology settings. So making it very clear that there was an implementation gap. The next step is this identifying barriers and facilitators. And it may be for your problem, nobody has looked at this. In our case, it looked like there'd been some work in this area. So we did a systematic review of all of the qualitative data on barriers to implementing collaborative care and depression treatment and screening in cardiac settings. And you could see here on the provider staff side, the star indicates the ones that were the most where there's a lot of consensus around is this lack of knowledge and skills, providers felt like, I don't really know how to do this. I don't know how to prescribe an antidepressant for some of my patients. And this lack of belief that this was their problem, a lack of reinforcement as well in terms of feedback. On the patient side, the focus really a little bit of lack of knowledge. I didn't know there was this link between depression and heart disease, but this lack of resources to meet the needs of from a health literacy and language, mobility perspective, lack of peer support, and discomfort discussing mental health with their clinicians. And a big one was still motivation of like patient stigma and this feeling like, even if I treated my mental health, I don't think it's going to make a big difference necessarily. So we spent a lot of time now mapping, and this is part of the nerdy part of implementation science, where we mapped all of these barriers to different types of strategies. And so if you have a capability barrier, which is a knowledge barrier, then you need some type of educational intervention. And these then map to, if you're a policymaker, you might also be mapping these to policy categories, like maybe I need a service provision, like the ABPM service, which we had a legislation, et cetera. After we did this entire kind of theoretical, and so this is all based on behavioral change theory, we then did some user-centered design of, we hired someone from Coca-Cola, we're going to sell mental health treatment to cardiologists and primary care patients, and did this kind of iterative approach over and over again, designing and redesigning a multi-level strategy that would target those interventions. So for example, for one part, we would iterate and say, okay, we won't go forward until we actually see a pre-post change in all the barriers that we talked about, like stigma and access and motivation and other components like this. Awareness of options, we kept titrating over and over again until we came up with a strategy that would target the barriers that we had been thinking about. So at the healthcare system perspective, the feeling was that there are a lot of collaborative care models that were being increasingly reimbursed across healthcare systems. So this is now widely reimbursed by Medicare, et cetera. And many of them are in primary care settings. So the thought was that we would leverage the collaborative care programs in the primary care setting. So we're still talking about cardiology here, and send our patients over to this collaborative care program as a way to find, and part of this would be doing some problem solving meetings and meeting with the behavioral health providers to make sure that they understand that treating a heart disease patient might be a little bit different. You need to do a little bit more activation, focus on their behavioral risk factors, giving them some technical assistance and prompting, and ongoing kind of learning collaborative meetings over several years, I think, to this point where this is still happening. So you're activating them to be the ones that kind of lead these meetings themselves over time so that they continue to meet even after we walk away. Some education for the cardiology and primary care doctors. And then the big wish was, can you take this out of our hands? Is there a way to get this done without us having to do too much? And so one component was a decision support tool where patients would be screened, activated, they'd focus on which mental health treatment to focus on, which behavioral risk factors like adherence or diet or exercise to kind of focus on. And all of this data would then be sent to a care manager who would then take over the care. And so we're in the midst of completing this trial now. This is a modified step wedge design across 15 clinics in our healthcare setting. And we made sure that we had a mix. We had Medicaid only, commercial only insurance kind of settings. And we have about 5 patients left to recruit out of 350, so we're almost there. And so pre-implementation, they just got care as usual. And the implementation arm has been problem-solving meetings, clinician champions, behavioral health, social work meetings, and some patient activation with tools. So the hybrid design allows you to really focus not just on so you're looking at effectiveness outcomes. So we still care about depressive symptoms, quality of life, and cardiac outcomes, but also implementation outcomes at the same time. So things like did we actually get patients to complete depression treatment? Did we get collaborative care acceptability and feasibility and fidelity? Did we see any improvement in that pre versus post? So we getting clinicians, and so far our preliminary sort of conceptual model, the thought is that patient activation is a more upstream target of the tools like this. And the thought is that this will improve depression treatment uptake, depressive symptoms, behavioral risk factors, and hopefully cardiac outcomes. And so some of the preliminary data we're finding is that we're seeing, which is what we actually hypothesize, a 15% increase in provider behavior. And it's actually been more effective in the cardiology settings than in the primary care settings, which is very surprising. So we're seeing more cardiologists prescribing antidepressants, referring patients, talking to their patients about grief as we're doing the kind of chart extractions and going forward. So it just gives you a utility of how to conduct these kind of really hybrid designs, mechanistically driven types of interventions in your setting as you kind of go forward with your various problems. So where do we go from here? In terms of more advanced implementation science methods, there's been this kind of interest in disrupting the pipeline, right? So we know that we wait until implementation to the very, very end. And there's been a lot of interest in starting to think about, can we start thinking about this at the discovery phase? Should we be thinking about implementation? Some of us were part of a Lancet commission recently of like, as you're designing your efficacy trial, should you be thinking about implementation from the very, very beginning? And my postdoc, now assistant professor, took a look at this and said, what were some of the barriers to cardiac rehab? So using the implementation science frameworks that I talked about. And she looked at, and this is a nice way, and this is the utility of some of these frameworks. You can see for clinic-based cardiac rehab, many more outer contextual factors, right? And inner contextual factors, social distancing at the time with COVID, limited number of staff. But when you think about home-based cardiac rehab, many more barriers at the patient level. I don't feel safe doing this at home. Where am I going to get devices? Where am I going to get a treadmill? And all of these other things that you start thinking about, technological issues, who's overseeing and monitoring the patient? How are you going to actually do that? And so she redesigned cardiac rehab from scratch. Like, if I was thinking about implementation from the very, very beginning, how would I have designed a hybrid cardiac rehab program? And you see this kind of mixture of home-based and clinic-based, and maximize reimbursement while also making sure that you're finding very effective ways to make patients feel safe. I think we underestimate the feeling safe component that happens in cardiac rehab. You have someone monitoring you and watching you as you exercise, and doing that at home may not translate very well. Finding the space and all of these other things. So really thinking about implementation and testing it in the real world with existing staff. So cardiac rehab staff will be doing this, both the clinic-based and the home-based cardiac rehab. And she just got notice of award today in terms of her first R1. So that's very exciting. So some of the pilot already showed some really early kind of differences in completion rates and adherence and no-shows, and some of those implementation outcomes that we care about, affordability and satisfaction, and other things like that. It's from our pilot feasibility trial. The other area that we're spending a lot of time starting to think about is this issue of reach versus effectiveness. And so you might be dealing with this, and especially in the cardiovascular disease realm, is that we have a lot of interventions and it's impossible to implement everything. And there have been some thought leaders who believe that we should be implementing the things that have broader reach, but maybe are not as effective. And you might have bigger population impact if you focus on those interventions where, maybe it's not as effective, but we know everybody can afford it and everybody can get it. And maybe that will have a better population impact than the kind of niche drugs that are very, very expensive that nobody can really afford, or there are all these kind of barriers to kind of widely disseminating. And so there's been a lot of interest in really thinking about population impact and the fact that maybe you can't do both reach and effectiveness at the same time. Other areas that are kind of coming forth in the field have been this area of stakeholder engagement. And Ron Adner, in his book, The Wide Lens, actually stated that you shouldn't even try to implement something that doesn't work for every single person and every single stakeholder, right? So it needs to work for everyone. And I think that's the reason things like Ozempic have been easy to implement. Industry loves it, clinicians love prescribing it, patients love taking it, right? You haven't really needed very much to implement that. It needs to be reimbursed, but other than that, I think at least in our high-risk obese patients with diabetes, it hasn't been and that's where most of the evidence is, if I were to think about mining the evidence, it's been not very difficult to implement. And so if you're thinking about your problem, like, does this work for everybody? If it doesn't work for at least one person, it's probably not going to be very successful in terms of thinking about implementation. And then very, very high level implementation science has been, how do you design implementation strategies? So I talked about all of those 9 categories of implementation strategies, and you can work to map barriers to strategies, but there's been a lot more interest in, like, are there different ways that we can select strategies? So we're doing things like innovation tournaments where clinicians come up with the strategies that we're going to test. And we had something like a Reddit type where you're upvoting and downvoting, and people were fighting over what was the most acceptable kind of approach, more or less. And so that's been one method that we're using to identify implementation strategies as we're kind of advancing the implementation science methods that we have worked on. And then from a Other things that we're doing are things like conjoint analyses. So this is done a lot in market research, where you're asking, would you rather do A or B? Do you want an audit and feedback and an educational presentation, or implementation team and conduct local assessment? And so as you do many of these, it spits out, these are the driving implementation strategies that clinicians find the most acceptable if they were to follow this guideline. And so this is something else that we're starting to kind of use in terms of advancing. This is more advanced implementation science methods as you start thinking, how do you select from all the different strategies? What are some methods that we can use? And then more recently, we just got a grant doing more on predictive analytics of really starting to think through, are there ways that we can better predict which patients are suited for which interventions, especially in the behavioral cardio-oncology world, and also starting to use implementation science just for qualitative analyses and linking barriers to different implementation strategies. So there, I think, is a lot of I think there's this whole field. I think there are some, we have to be very careful. I think you have to validate still a lot, but I think there's a lot of interest in this area. And then finally, one of the main bigger pieces that we started doing is thinking about a policy lens. And I think if you're really doing implementation science and you really care about how do we widely implement something across multiple healthcare settings, taking a policy lens and working with policymakers, I think you can learn a lot from in terms of implementation science. So a couple of years ago, I worked as an implementation, and I'm still working with them as an implementation science consultant. New York State decided, let's implement collaborative care. We know it impacts cardiovascular disease outcomes. We know it works. It's been effective. Let's see if we can do this. And so they provided some funding and technical assistance to 32 sites across New York State. And then they expanded out to 611 sites. And they really provided technical assistance, which is calling care managers, asking them, how can we help you? How can we provide you training and get you set up for doing collaborative care, fee for quality, so reimbursement if you can show improvement in depressive symptoms, and then reporting back data to the state over and over again from a quality monitoring perspective. And we're looking at this data now. And so the early implementers, we found that with these in place, you had to have all of these strategies in place for us to see the effectiveness of the original clinical trials. And that gives you a sense of just how hard it is to implement evidence-based interventions, right? If you need all of this, somebody has to pay for this to some extent, but implementing things it doesn't just happen by itself. And we found that those clinics that were doing this on their own, without technical assistance, without any help, were actually showing harm for their patients, right? And so patients were actually having worse outcomes and poor outcomes. So it really makes you wonder, if you don't have these in place, there is the possibility that you might even be harming your patients as you're just implementing evidence-based interventions without kind of strategies in place to make sure that you can kind of bolster the effectiveness that you saw in the original clinical trials. And we're spending a lot of time, this is a great opportunity to think about mechanisms. And so in our qualitative data of our original clinics, most of them were still doing collaborative care years later, 5, 6 years later, and we looked at their barriers. And so things like funding stability, training, knowledge, communications were less often brought up, which gives you a sense of the mechanism by which those strategies were working, right? The technical assistance, the training, the quality monitoring is probably happening through those mechanisms. But things that were not being targeted were resources at the local context, patient engagement, and staff engagement, which is the primary care clinician. So we're in the midst of testing. We just finished a large trial where we tested additional strategies in their worst performing clinics, and we found some improvement when we did technical assistance at the local level and really focused on iterating and adapting the collaborative care to meet the needs of the clinic. We saw this kind of improvement in patient optimization and depressive symptoms that we saw in the kind of original trials as well. It gives lots of space and lots when you have a bigger playground. And then one of the last big pieces that I think the implementation science world is moving towards is areas like thinking about mechanisms. And so as I talked here, we're starting to create these kind of causal loop diagrams, and getting a sense of like, what are the moderators? You need a very high quality, engaged care manager and psychiatrist. You need a care manager program in general from a precondition, but thinking about the mechanisms and those determinants that I talked about before, things like training and funding and leadership engagement, we think are some of the mechanisms and the determinants that this technical assistance is actually targeting. We're looking at moderators. They seem to be less effective in FQHCs than other settings, right? You need to have the right billing infrastructure. We found that the fee for quality was actually not very effective, just because people didn't have the precondition of the right billing system to actually get this done. And so we're looking lots of different moderators and getting a sense of what predicts improved depressive symptoms and reach within these collaborative care programs across New York State. If you really want to do true implementation research, I think that's always an opportunity. So going back to some of the challenges that I talked about before, I think I've left you with the importance of doing more hybrid effectiveness implementation designs, especially as you're thinking through especially if you think there are still effectiveness questions that still need to be answered. Trying to look at effectiveness while also looking at implementation, I think is one area that could promote implementation science in cardiology. There's been a lot of interest also in thinking about what is the active ingredient. If your original trial, if we still don't know what the fidelity was or what the active ingredient was, then it's very hard to kind of replicate this in the real world, right? So really spending time thinking about, so we thought about behavioral activation or the mechanisms of action of our intervention. So we're targeting that mechanistic underpinning in terms of the real world interventions that we're designing. And then some of the work we're doing is starting to design for implementation. If you're doing efficacy work of thinking about designing for implementation, thinking about things that have broader reach potentially than are effective, or some of the things that I'm challenging people to do more of. And then some of the work I think we've really shown that stakeholder engagement through the discrete choice experiments and innovation tournaments, getting the patients and the providers to come up with the strategies that you are going to be testing on them is another approach that I'm starting to see a lot more of targeting patients, which is what we did with our tool, to then activate clinicians is one mechanism or one approach, I think, for improving the uptake of evidence-based interventions. And then I think given the preponderance of just local QI, of really thinking about if you're going to be doing implementation science, of making sure that you're doing it amongst a very broad, diverse swath of different clinics, so that it's not just, oh, I'm doing this in 5 clinics that all look alike. We want to be able to generate generalizable knowledge. And maybe you don't have to do it in 611 clinics necessarily, but really thinking through. And this is, I think, an area for helping us understand the mechanisms by which our strategies work or don't work, I think, in certain settings. So in conclusion, I hope is that I gave you a little bit of a sense of how implementation science can provide tools and frameworks for explaining why and how and where strategies work or don't work. That it involves this kind of 4-step process for identifying evidence-based interventions, examining barriers, and testing strategies before evaluating. And then I think really thinking about applying implementation science to cardiovascular research, especially like in areas like behavioral cardiology, of doing this evidence mining and thinking about ways you can spur innovation and promote uptake of evidence-based interventions, I think is key to kind of advancing the research that so many of us have spent years and years kind of building, but how do we move it to the next level? And then future directions, I really think, will be this kind of design for implementation and this kind of mechanistically driven policy lens. So thank you very much for having me. I hope I'll hear from you. I had great discussions with many of you, and I'm looking forward. I left enough time for questions and discussion as well.
Yeah, I can start. First of all, thank you for sharing your journey and this really new science. I mean, we talked a little bit about the fact that you kind of got in on the ground floor, and this is still an evolution. I think there's a tension, and I certainly feel it between the mechanistic approach that you've applied implementation science and just getting something done.
Yeah.
And so I want you to maybe give us a sense of how, if you were guiding or consulting groups, I could say, just for the group, I think that's a tension that we feel here because we are an increasingly large academic health system where resources are limited, and we might want to target certain mechanisms across different sites or components or or patient cohorts. So we need to know the why to see if we can replicate and extend it. But there might be situations where we just want to make sure that more people are on SGLT2 inhibitors at discharge at Yale New Haven Hospital. And
Yeah.
how do you navigate those types of challenges, and how do you guide people to do quality improvement versus implementation science?
Yeah, I think that's a great question. I think I usually start, so obviously the urgency helps a little bit in terms of how much of a priority is this? Does this have to happen now? During COVID, we saw a lot of this has to happen now. We just can't, we don't have the time. And maybe there aren't questions to be, sometimes there's not a scientific question. We don't really need to know why. I think that's been my concern sometimes, that everybody wants to do implementation science, but we don't really always need to know why or how something is working. Maybe it's being scaled adequately. It's just something very small and easy that we need to do, right? And so my urge is that people don't overdo it with the implementation science, I think. But I think we can steal from implementation science. So I had a mentee who just wanted to focus on telemedicine during COVID. And we focused on using like REAIM frameworks. So some of the implementation science frameworks to evaluate how things worked. And it allowed her to kind of see, we were able to see, hey, this was great in the beginning, but the maintenance was terrible. It's a more comprehensive way, as opposed to just looking at one outcome and only caring about one outcome, of more comprehensively thinking about all the various outcomes. So that's ways that something that was very quality improvement could steal from implementation science, some of the frameworks, et cetera. I still think the other area where I think that you can just do things rapidly are some of the work that I did with the policymakers. That wasn't a randomized controlled trial. They just got out there and just did it. And there are still ways that we've done like propensity matching and other things that we can try to still evaluate. But sometimes, we knew collaborative care, it's been tested in over 100 clinical trials. We didn't need to test the effectiveness again. There was no need for a rigorous trial. We just needed to get this out there, right? And so we were still able to, even doing that, we were still able to think outside the box to think about ways to evaluate that program. So there was still some rigor, and that we understood, okay, what was the cost effectiveness, and still allowed us, I think the qualitative stuff still allows you to understand some of the mechanisms, even for a program like that, right? I think the areas where we should be spending more time is where, and thinking through a little bit, is the areas where we still really don't know what the active ingredients were of that intervention. And that's a little bit more difficult in the behavioral interventions than drugs. Like we already know, like this medication works definitely, or maybe we just don't know which populations potentially. But the interventions where it's still not clear why this worked or how this worked, or do we need the entire intervention, or do we just need a component of this? I think those are the types of things I would reserve the resources of implementation science to do it the very rigorous way. And so I usually urge people, we can steal parts of each of these different scientists. It doesn't have to be done in this perfect way. I would reserve the true implementation science for the places where we really have urgent questions, that we still don't understand how or why this is working. And that not understanding how or why this is working is the reason why we're not able to scale. And regardless, I do think that you need to spend a lot of time. This is why our scientific statement had a whole section. Nobody ever starts with number one. People just start going towards the barriers and facilitators, and spending the time in mining the data to get a very good understanding. And sometimes, and if you think you have that time, you have the funding, et cetera, those are the things I would kind of reserve that time of work for.
Thank you. That was very thought-provoking. So maybe.
Yeah. Yeah. Yes. Yeah. 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 Mm-hmm. Yeah. Yeah. Mm-hmm. Mm. Yeah. Yeah. Mm-hmm. Yeah. 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 You know, knowing the patient, and he's had a multi-million dollar workup. The thing is that what's interesting, I didn't say this, it's reproducible on exam, right? So there are some things where we can keep going down that pathway, but he's so anxious and so clearly depressed and hasn't even tried anything. So I still feel like this is that push and pull within this patient. We can't implement everything. He's just one human being. Maybe we can do one at a time necessarily, but the fact that with all the research that we have on the relationship between negative emotions and cardiovascular disease, which is clearly, and it's not clear that it's just his chest pain that's producing his depressive symptoms. When he's more anxious and depressed, he has chest pain too, right? So it's hard to say which came first sometimes for a patient like this. But the fact that with all the research that we know about cardiac rehab and even mental health treatment, collaborative care models, et cetera, that he hasn't done any of that, I still think that I would implement those first before anything else. The fact that we haven't even tried any of those, it still boggles my mind in a patient like that. And I think that's the one of the missing links that we're just not paying attention to, at least in even my practice where I deal a lot with this. It's just boggled my mind one day when I realized after his he's had 3 casts, I think, at this point, that I was like, we haven't even tried an antidepressant in this patient who's having like what sounds like some panic attacks as well, right? And so there is this kind of push and pull as we ask ourselves as clinicians, why don't we want to even address that? And is it easier for us to order more tests than to address the emotional components of their psychological, the psychological components of their cardiac disease? Even I feel apprehensive of bringing it up to patients because they're going to say, oh, you're not paying attention to my actual symptoms, et cetera. And so it's very tricky. And I think this is some of the reasons why it's so hard to kind of intervene. And we spend a lot of time thinking about, and so I think there's still roles. You can still order all these diagnostic tests. I just don't know that you're going to find anything in a patient like this. I'm not convinced that it's not a big component of this is not just his loneliness and he feels better. And one part I didn't put in this case is the minute COVID happened, he stopped going to the emergency room because he was so scared of COVID. His chest pain kind of went away, right? So there's a little bit of, you can tell that there are psychological factors that are going on here that he realized, oh, I'm not having a heart attack actually. And I didn't actually need to go to the emergency room as much as I thought once there was another fear that was surpassed the fear of the chest pain and the cardiac events. This is not to say that he's very high risk of having another event, right? He's had multiple PCIs. He's definitely at high risk, but not treating his depression when we know that this also can reduce his risk seems like the elephant in the room to me sometimes.
Erica raised her hand online, and if she would like to unmute herself and go ahead. Still there? Just a minute. Okay. We'll follow up afterwards.
Okay.
Any other questions in the room or online? And if you're online, please unmute yourself and ask a question. Do you have any chat? No. Well, without any other questions, maybe we'll have more time for people to join Natalie here in the front and ask individual questions.
Awesome.
Sorry, were you able to hear me or no?
Yes, we can hear you.
Oh, did you guys just end or? Okay, I'll just ask
No, go
really.
ahead.
Sorry, I'm not there in person. So my question, Natalie, is around knowledge dissemination with implementation science. I feel like there's 2 hurdles. Like one is to get the science out there into peer-reviewed literature, right? And there's this big hurdle because of single site data or, this is your experience or these are your mechanisms. The mechanisms here are different. And then the other hurdle is like, the audience, right? So the audience is a health system. It's multiple stakeholders. It's not a single individual that necessarily can make these kinds of big, bold changes and adopt learnings from other places and implement them at their institution. And so I wonder like what your thoughts are on like the options for disseminating knowledge from implementation, and if we like have the right avenues for doing that. Like, have we organized ourselves meaning like the health systems or medicine writ large in ways that are going to prime us to be able to take up the findings from another site's implementation science learnings and adopt them and implement them in a different space. Like, what are your thoughts on that? Yeah.
Yeah, I'm starting to get a little bit concerned about the field sometimes. I'm like, are we going to have to now work on implementing the implementation strategies, which would be really unfortunate. And I'm worried a little bit about that and the pace of implementation. If we were trying to, are we extending the pace of implementation by spending so much time on the mechanisms, which is why I urge people not to focus only on the implementation. So I'll answer your first question in terms of the journals. And I do think that there's been more interest though. We have to remember that this is a fairly new field. It's not been around for a million years. Like, we shouldn't be expecting this to be like in every single journal yet. And I think we have to be aware that this is very, very hard to kind of get across, first of all, the science of this. And then the results are also very tricky because the whole point is that you are publishing, and this is why it's so hard to get into certain journals. You're supposed to be publishing not just this randomized controlled trial showed an improvement in depressive symptoms, but you're supposed to be publishing the how and the why. And that takes a lot of space to do, which is why I think most of the work is still ending up in journals like Implementation Science, which still has a really high impact factor. But I think that's going to be the trickiest part, is that I just don't know that we can even, if we just focus on journals that like JAMA, et cetera, that we're going to be able to make the impact that we wanted to. You can't glean a lot from like a very quick perusal of 4,000 words of what we don't know what happened or where or who delivered what, so all of these components. I do think that there will need to be a push to, like, in your supplementary material, have the entire protocol of how you did this. And that's been the push of the field, is that we're not just showing what happened at the end, but the how it happened, and who delivered what, when, et cetera, and how you kept those folks motivated over time, right? So I do think that's going to be some of the barriers, big picture. But I still think that's the way that most administrators and healthcare providers glean data, is through these larger journals. And I think it's more just continuing to work with them. I know JAMA Network Open is being much more open. They publish our implementation science paper for a lot of, and we have in our method section, like how this happened and where, and all of these other components that are absolutely needed to kind of replicate this. So I still think that there's an avenue for this. I also think we're starting to think, conferences have often been the place where people kind of learn from each other. And right now I usually go to the implementation science conferences, and they're very nerdy and very about methods and not a lot about what happened at the end necessarily. It's very much about advancing the methods of implementation science. So I still feel like we're in an echo chamber, just talking to ourselves instead of disseminating out. And so some of the things that we've started thinking about, ABMR, I think, is going to be focusing on the science of communication and gleaning from our communication dissemination experts in our field of how do you disseminate knowledge? How do you disseminate this? And some of this is making it into newspapers, making it into like talking to our marketing experts of like, how do we actually get this out there? I don't know if television ads and all things like that, but LinkedIn, like social media, this is how increasingly people are getting knowledge. And the more that we do this, I think it will be easier for us to kind of disseminate at least the findings of implementation science. Now, the field in and of itself, I just don't know that everybody needs to know everything about implementation science. I don't think that's integral to gleaning from it necessarily. And so to me, it's still like, it's going to be like epidemiology or anything else, where you're going to have a whole bunch of, of implementation scientists, and each of us are going to have our little niche, just like epi and any other kind of field that you usually see. But I still think we have to start thinking a little bit outside the box, but I don't know that we need to necessarily rush it just because it's still a new field and data is still, a lot of the trials, when we did our scoping review, the majority of them were still protocols. like almost everything that fit the criteria. And I've been on lots of different scientific statement as the implementation science person, and my section's always tiny. There's nothing there. We're still at the protocol stage for a lot of these interventions. And we don't even know what the results are. And my assumption is that some of them are going to be null, obviously, and we're going to have to learn from that as well. And my hope is that those kinds of trials will also be published so we can learn from them. I don't know if that fully answers your question. I think it's complicated, and it's a good question overall.
Thanks, that's great.
Well, if there are no other questions, let's all thank Natalie for.
Have to do anything else? No, just leave it. Okay, great. Thank you. Thank you so much for inviting me.